Thank you for attending our webinar today on improving care with complete medication data. Like I said, we have a powerhouse group of speakers that I'm really excited to moderate today's panel. We have Stephen Lane, Chief Medical Officer at Health Gorilla, also member of the High Tech Committee. We have Jim Jirjis, Chief Health Information Officer at HCA and member of the High Tech Committee. We have Colin Banas, Chief Medical Officer at DrFirst and former Health IT Fellow at ONC, and Shelly Spiro, who is the Executive Director at Pharmacy HIT Collaborative and former President of the American Society of Consultant Pharmacists. My name is Avery. I'm the Executive Director of Strategy and Partnerships at Health Gorilla, and I will be moderating today. Before we get to our panel, I just wanted to frame the problem that we're all trying to solve here. The bottom line is that gaps in medication data lead to worse outcomes. Medication non-adherence causes 10% of all hospitalizations. 1 in 3 medication prescriptions are never filled, and adverse drug events cause 1.3 million emergency department visits annually. Given this problem, Health Gorilla is very committed to solving it. We now, through partnership with DrFirst, have access to pharmacy data solutions from virtually every US pharmacy. So we are now bringing in medication data from virtually every US pharmacy. And ultimately what we are building is this maximal usability of health data. So we are combining EHR data, lab data, SDOH data, and pharmacy data to really give that holistic view of a patient's health so that we can ultimately drive more positive outcomes. And with that, great segue to starting our discussion today. I have some moderated questions that we'll be going through in the first about 30-40 minutes of the webinar. And then I do encourage all participants to submit their questions through the Q&A box at the chat below. We will have time for audience questions near the end, and our panelists also have the ability to write written responses. So please do, throughout the webinar, submit your questions in the Q&A. So I am going to start with a fairly simple question, but with many ways that we could take this answer. So I want to know, how does complete medication data, including pharmacy dispense data, improve patient safety and drive better patient outcomes? And I am going to start that question with Shelly.
Well, thank you very much, Avery. First off, medication data is highly codified on the claim side. So as an example, if a pharmacist receives an electronic prescription from a physician's EHR system, like from DrFirst, we would be able to receive that information electronically and then submit a claim from that dispense data. The claim is missing information such as the directions for use or the SIG. It is also missing information in terms of, was it picked up by the patient, or what we call the fill status. So there's some anomalies in the dispense data that we're receiving. So as pharmacists, especially pharmacists that are documenting clinical services within their pharmacy management systems in their clinical documentation module, add additional information such as over-the-counter medications, or if the patient paid cash for those medications, in what we call a comprehensive medication review, where we're reviewing all the medications through interviews that we have with our patients and documenting that in a very codified way in exports like a FHIR resource standard, such as the FHIR Fast Healthcare Interoperability Resource Standard, such as the Pharmacist Electronic Care Plan. Now, we've proven this in the use of this tool in independent community pharmacies across the United States. We've had millions of electronic care plans being generated and prepared for exchange, which includes a reconciled med list in that. So if you're looking at reconciling medications, having medication information, such as through the script medication history standard, you would be able to see at least what was sent for a claim, not necessarily what the patient actually picked up, as you saw in your previous screen of potential adverse reactions. Without the pharmacist's intervention and counseling the patient and going over all their medications, especially for patients with multiple comorbidities or patients that are high risk, then we don't see as good of outcomes that are actually occurring on those patients. We see better outcomes, and we have a way of documenting those interventions and outcomes and reaching the patient's goal in exports like the pharmacist's electronic care plan.
Fantastic. I will also open it up to other panelists.
Oh, sure. I think Shelly did a great job of describing it. What the other big elephant in the room, and it's especially popular in recent days, is that a lot of prescriptions don't go through claims. So if it didn't go through a claim, if you used cash because you weren't near your deductible, or you wanted to use a copay assist card, or some of those coupons that are out there, some of that stuff never hits a claims, and depending on your data source, you might not see that fill at all. And of course, DrFirst, very proud to have a very complete medication history feed, because as an internist, managing medications is pretty much like the one thing that I better get right, because when we get it wrong, that's how patients get hurt. And I think we all have multiple anecdotes, and there's plenty of literature to back it up, that when patients aren't, when I don't know your full list, when I don't know what you're taking, and I forget to give you something that you need, or I'm giving you something that, can have an adverse reaction with something you're already on, it's precisely how patients get hurt. And your statistics at the beginning show that time and time again.
Hey, yeah, I'll chip in here. Jim Jirjis, as an internist also, I think the question was about about medication safety, right? And I think both of them made some great points. Colin, just to add to what you were saying, as our population ages and as our research and development as a country becomes more successful, the good news, bad news. The good news is we have far more treatments than we used to have. But the bad news is patients are on far more medications, right? So admitting a patient to the hospital, or even seeing them in clinic, they're often a geriatric patient, and they often have upwards of 12 medicines.
Mm-hmm.
And what we're learning over time is, the amount of time it takes in a time-crunched environment to actually do medicine reconciliation well can be 45 minutes.
Mm-hmm.
And without that, all the drug interactions, the dangers to the patients of omitting, as Colin said, an important medicine, drug interactions, or having the patient on an inappropriate medicine. Because the patient on that many medications, especially as they age, it's confusing to them, and they may misinterpret what they're supposed to be taking. So that's the here and now. But if you look at the other good news, bad news, good news is with pharmacogenomics, as we learn more, as more information becomes available, even going beyond the human, the physician, the clinician processing all this, it's incumbent upon us to have the computers understand what medications the patient's actually supposed to be on, and what medications they're actually on, so that it can interact with this, all these other drug interaction, pharmacogenomics, et cetera. It's just imperative that we get this right now, because it's only getting more complex, and the possibility for mischief is really high.
Mm-hmm.
And I'll chime in also, as a family physician, caring for people across the lifespan, I want to emphasize the importance of the entire medication history. that a patient has had over time. I mean, Jim and Colin and Shelly have all mentioned the importance of having the current active medication list, having that complete to make decisions today. But also a lot of our decisions need to be informed by what's happened before, what prior drugs have been tried, what have been the responses to those medicines, were they stopped due to side effects, or allergies, et cetera. And then also being able to calculate the total lifetime dose of certain medications is important. And I know for me, when I'm going to treat something, when was the last time you were on antibiotics? When was the last time this sinus infection or this pneumonia occurred? And how did you respond then? The need for us to think about antibiotic stewardship and not giving someone the same antibiotics over and over again. So I think that there are so many opportunities to improve outcomes with this complete medication data, both current and historical.
Thank you, Stephen. And, I want to circle back to something that you just said, Jim, about, reducing this administrative time, for example, of going through a medication list. Can we talk about, how, of course, as we just said, improving patient outcomes is the baseline. Nobody would argue that that's the baseline. And we also need to understand how integrating pharmacy data drives revenue, how it makes it more seamless to serve the business needs. So Jim, could you speak a little bit to how complete medication data can help drive business needs?
Absolutely. It's so funny because when we think about the multiple customers, right, ultimately it's about the patient's care, right? But we also, as informaticians, we serve those who serve patients. And so one of our important customers are our clinicians, nurses and doctors, right? And so we all know the nursing shortage. I mean, I don't know any zip code that doesn't have problems with the workforce shortage. We know there's provider shortages often. There's time constraints. And so as we think about how we support those who support the patients, there's really two simple metrics that everything should follow. One is, are we making our clinicians more efficient? And the second is, are we helping them make better decisions? Now that's patients also, but so many of those who use the medications, lists, et cetera, are those who serve the patients. And so by actually taking, I'll give you a good example from an actual case. I had a patient admitted through the emergency department with a variety of harrowing symptoms. And when I went and I thought, boy, I wonder if these are medication related. So when I went to see the nurse in the ER had done their part of medicine reconciliation, what meds were the patient on at home? But because they're in such a time crunch, ain't nobody got time for that. Mm-hmm. They actually had the wrong list. And so wow. I circled back with that nurse. I said, can I just ask you, not trying to get anyone in trouble, did you actually confirm with the patient what they're taking? And after 5 minutes or so of hemming and hawing, they finally said, I just didn't have time, no. Well, the answer to what was harming the patient was what they were taking, and it wasn't on the list. And what I'm trying to say is, if it was easy and it was just, it magically happened, like 21st century cures, the information and its meaning should follow the patient wherever they go, then in the med reconciliation process, that would have just naturally appeared before the nurse, who could then confirm it instead of having to type it all and delete stuff, right? And that's what I mean by efficiency. In addition, it frees that nurse up to do other things. Mm-hmm. And everybody and their cousin right now is trying to figure out how to take workload off nurses. And they're an important part of medicine reconciliation in clinics and the hospital. So when I talk about efficiency, yes, it saves time, but it's the opportunity cost, it's the opportunity benefit of them being able to do something else that's higher value. And that example also says it enabled them to make better decisions. And those are the two simple metrics. I hope that's a good example of what I mean by both.
Yeah, I love that, Jim. And actually, Shelly, I was just going to ask you from the pharmacist perspective, could you weigh in?
Absolutely. So in 2010, the Pharmacy HIT Collaborative was formed by the National Pharmacy Professional Associations to assure that pharmacists that provide these clinical services are integrated into the national health IT infrastructure. And because of that, and just because of what Jim has talked about, pharmacists are trained to do a true medication reconciliation. And that's why we set up SNOMED codes to capture when a pharmacist has reconciled a medication list, because the medication reconciliation process is an evaluation process. It's not just comparing one list to the other. And there are some software applications out there that help with medication reconciliation for clinicians. But when a pharmacist is doing true medication reconciliation and optimizing the medications that the patient is on, this is a process that we're trained to do prospectively, including bringing in pharmacogenomic information to prevent potential adverse drug events. This process by pharmacists, number one, is not paid for in all cases, and it is quite an extensive process, but we have found great outcomes that have occurred when pharmacists have intervened. Now, in terms of discontinued medication and lists in relationship to non-active medications or discontinued medications, we've also worked on coding for that documentation, so it can be transmitted in something that we're working on now, which is a transitions of care document called the standardized medication profile that would have a reconciled med list, including active and discontinued medications. Now, it's not just for the patient and for the clinicians to know about discontinued medications, but it's also important for the payers to understand, especially for prior authorization, if they need to know that those medications have been tried before, and if the physicians are coding their medications correctly, such as statin use in diabetic patients that require certain types of coding in order to make sure that that patient is maybe they can't take a statin and that information has to be discontinued. These cause additional problems downstream if we don't proactively reconcile the medications and come up with the correct information on medication data.
Yeah, and just to continue on that theme, Jim talked about the efficiency or the reducing cognitive burden, giving back. We call it repurposed time, but it's basically, how can I save you from mundane so that you can, practice at the highest of your education. The other, it was right there. The other ROI was right there in your opening slides, and that is adverse events. Yeah. They're expensive. Readmissions are expensive. There are things that we no longer get reimbursed for. There are things that are publicly facing that, or CMS star ratings. There's all sorts of things related to outcomes that, have an inherent ROI that may not, we may not always talk about, but it's there. And so there is a huge incentive to get this correct.
Shelly, there was a good question in the chat or Avery about what if something goes wrong that I thought would be fun and yeah. I don't know if you want to read it. You can each comment.
You know what? That's actually exactly the next moderated question. So let's roll it all into one. So tremendous growth and investment in health IT, tremendous growth in technology. How can technology support medication reconciliation, adherence, medication reporting needs, and also what happens when it goes wrong? How are we dealing with patient safety as these new technologies are being developed? Actually, Colin, I would love for you to take kind of a first stab at what does it mean that we're seeing so much investment in health IT, and what are the promises in the technology?
Oh man, how much time do we have?
Yeah.
I think with a lot of the problems that we've already outlined, whether it's clinician shortage, whether it's burnout, whether it's that notion of cognitive load that I was referring to earlier, it's only natural that we look to technology to improve upon all of those things. How can I layer technology in a thoughtful and safe way that I can do a lot of these things in an automated fashion, or at least augment the clinician flow. And so I actually hate the term artificial intelligence, and I know I'd rather talk about augmented intelligence. How can technology augment? Because we're never going to replace the clinician, nor should we want to. And that's another important piece that I was thinking of while you were posing the question, is we have to make sure that the technology is done in such a way that there's still a human on the other end who's verifying, who's confirming, who's, there's always a check. And so, but yeah, just like other industries that have, looked to technology to improve workflow and bottom line, et cetera, medicine's just late to the game, but we're catching up quick.
Yeah, I'll be happy to add to that. I mean, I think that's a really important point, Colin, is that technology has come slowly to healthcare. And certainly medication documentation, especially e-prescribing, were one of the really early wins of health IT, where we've really improved the efficiency and the safety of transmission of medication data. But it's still relatively early days, I mean, as we've been saying, it's very challenging to put together an accurate, complete, up-to-date medication list and to keep that list accurate. I mean, as soon as somebody spends 45 minutes or has a pharmacy interview or whatnot, or if we do it in the primary care and the hospital setting, that's good for that moment, and it's as good as the process that was used to collect that data. And so I think what we need to look at how can we leverage technology as it continues to advance to make this process more accurate, more efficient, more automated, and how can we engage all of the members of the care team, including the patient themselves, in assuring that this data is accurate and up to date and codified. I think the codification is one of the key points, and Shelly was pointing to that earlier. But Shelly and I are both on a work group now within the Office of the National Coordinator for Health IT, where we're working on how do we advance the U.S. Core Data for Interoperability Standard, the U.S. CDI. What new elements of medication data need to be added to that as we're considering what's going to be in the 4th annual version of that standard, so as to be able to support the more complete, accurate, and safe exchange of medication data. So these changes happen slowly, but the good news is that we've got an entire industry of informaticians and clinicians and patient advocates and pharma all engaged in trying to move this forward. But I must say, for my part, I wish it moved more quickly.
I'll throw my head and bring on this too. Excellent comments by both. I think one of the interesting points in the question from the anonymous attendee says, we know that technology is great, but what if something goes awry? How are physicians protected against using the wrong medication data, parentheses, for example, if the patient match is incorrect? So one of the comments is, there's multiple Swiss cheese holes, if that when errors happen, right? Mm-hmm. And so we're talking about one of them, codifying the information, right? But if you look at all of us collectively, vociferously supporting all elements of what's going on with 21st Century Cures and TEFCA, for example, patient matching, great point made. If we don't get patient matching righter and righter, then there will be opportunities for flaws, right, that occur. So putting all of our steam behind every aspect of whether it's TEFCA or the APIs or US CDI, privacy, security, it's not just one piece, it's the whole enchilada. Because the real answer to this question, the hidden answer to this question is, let's not have these errors happen. Let's close Swiss, let's have Camembert instead of Swiss cheese, right? Let's get rid of Swiss cheese. We don't need the holes, right? And another comment, Stephen, you made is, the idea of democratizing the data, its meaning, its syntactic, having APIs, creating a marketplace with patient permission, mm-hmm. where we can support models where instead of waiting for my patient to come to the emergency room for someone to do medicine reconciliation, maybe the patient, the pharmacy, Shelly, pharmacist, maybe there's ongoing medicine reconciliation so that somebody empowered through technology with one of these new third-party apps, for example, maybe a business service, a health gorilla or someone could provide with payers, is technology empowered to reduce the cost, increasingly accurate medication lists. That's a wonderful new opportunity that would be hard-pressed and costly to institute right now. But you can see when semantic interoperability is more mature and when the APIs are being used, when this develops more, those kinds of solutions should be at hand.
Absolutely. Shelly, it looked like you had your hand.
I'd like to respond to this in a couple of ways, especially what Stephen said. Part of what we try to do is definitely engage the patient. And if you've been to your physician lately and you go to a wellness visit, medication reconciliation is one of those areas that you have to do. And there are apps that are out there now for helping the patient, number one, track their medications and reconcile the medications, and hopefully eventually be able to share that with the care team. Now, there are some health information exchanges out there that do collect all medication dispense data, very similar to the prescription drug monitoring programs and setting up registries that include all the dispensed medications that the patient is on. But as clinicians, we need to realize that that is not accurate information. It might be the patient didn't pick up those medications, but it's a starting point. And that's what some of these programs and apps do as a starting point to help the patient reconcile their medications with their clinician, and hopefully within the physician's EHR systems as they're doing medication reconciliation, or a hospital's EHR system, that they're being able to pick up that information. I think the other area that we see on the standard side in HL7, out of the EHR work group, there is a burden reduction task work group that's working on reducing burden, including accurate medication reconciliation that would lead to patient engagement. And those are areas that we're working closely with on the pharmacy side, because this is our realm that we do within pharmacy. Anytime a new prescription is received by a pharmacy, the pharmacist must review all the medications that the patient is on for potential drug-drug interactions, for assuring that that patient has accurate capability. And this is in all practice settings, including in the skilled nursing facility, where it is required federally for a consultant pharmacist to review that patient's medications upon admission or upon receiving a new medication. And so these are things that pharmacists are very used to doing. Our problem is getting these pharmacies connected to the other clinicians. And we're hoping that maybe organizations like Health Gorilla will be able to help us get those pharmacies connected so that we can share that information in an interoperable way. But we've worked through the Pharmacy HIT Collaborative, NCPDP, the Pharmacy Work Group at HL7 to assure that we have the standards in place for that connectivity outside of our own systems, so that we can share more accurate reconciled medications and improve our patient outcomes.
You know, I think it's really interesting. Thank you for that, Shelly. And I think it's really interesting to think about the fact that we know that there are adverse events today that we are trying to solve. And what's our risk tolerance as an industry for creating new potential adverse events, but with the opportunity to decrease the adverse events that we already know are there. So with technology, we're always looking towards how do we improve what we already know is a problem, and yet introduce as little new problems as possible. So I think we do have to remember as we're walking towards this new world, that the opportunity to reduce adverse events that are already there is really key, and has to guide our thinking. Yeah, Shelly, go ahead.
One of the things we've been working with the United States Pharmacopoeia on a project that came out of the National Library of Medicine on revamping how we actually do the clinical algorithms in relationship to adverse drug reactions. And we're in our second 5-year cycle on this project. Right now, our algorithms for drug-drug interactions are based off of a drug class. And we have found that this is a potential problem. Example being, if you have a patient who has an allergy of penicillin and you prescribe a cephalosporin, that you're going to come up with a drug-drug interaction, which brings on alert fatigue. And so what we're trying to do is get down to the actual product level information or the actual drug information, such as using RX norm and codifying the clinical manifestations with SNOMED CT. So we've taken several drug classes, proven that there are anomalies that take place in the current algorithms with drug-drug interactions. And so we've mapped out a workflow of potential adverse drug events, observations that we've occurred, such as rash, and what is that clinical manifestation, to the investigation, to the actual reporting through FAIRS with the FDA, to electronically transmit this information, to help with the information such as instructor product labeling on drug products, so that you're not just getting, nausea or vomiting and what percentage it occurs. But as we move to precision medicine and we move to more expensive types of drugs where more individual drug interactions can take place, we need to have the ability to capture that information, codify it, and share it not only with the care team members, but also with the government itself as they work with, such as the FDA working with pharmaceutical manufacturers to increase the information that goes out in direct consumer advertising.
Fantastic. I am really excited to get to this next question because I think it's a really interesting movement in the industry. So in recent years, pharmacies have increasingly been acting as providers. Legislation like the Pharmacy and Medically Underserved Areas Enhancement Act and amendments to Social Security in 2022 have underscored and supported the idea of leveraging pharmacists as providers, especially in rural areas. And as Jim mentioned earlier, with a shortage of other healthcare professionals, it's a huge step forward also, I think, in recognizing the powerful role that pharmacists play. And reportedly, my statistic that I have here is reportedly 90% of people in the US live within 5 miles of a community pharmacy, which makes pharmacies potentially some of the most accessible healthcare providers. So how are pharmacies today, both digital and physical, closing gaps in care? And what are some of the challenges they face in doing that? Obviously, Shelly, I want to hear from you. I would also like to hear first from Stephen. Because Stephen, as a family physician, I would love to hear your thoughts on how pharmacists can play a role in that continuum of care. So let's start with Stephen and then move to Shelly.
We talked about, the nursing shortage and how important that is. But of course, there's also a physician shortage, and especially in primary care. And I think that really individuals, patients need care. And if they can't get it, from one place, they should certainly have the opportunity to get it from where they can. And we want it to be care that's provided by, well-trained, well-supported professionals that are prepared to provide that care in a safe and effective manner. So pharmacists, I think so long as they are working within their scope of practice and scope of knowledge, so long as they are armed with the data and information and decision support that is needed to exercise that practice, are a great opportunity to extend the care. But I think the important thing is to realize that any of us, needs to practice within our scope, within our scope of knowledge and expertise. And we need to share the data amongst all of the members of the care team, whether they're seeing someone on a continuous basis or on an ad hoc, one-time event. So I think the idea of pharmacists as a member of the care team, pharmacists as clinicians, as in fact they are clinicians under the HIPAA rules and all of the federal designations, should really be empowered to access patients' clinical data, to support the care that they provide, not just their medication data, but all of the data, the problems, the allergies, the immunization history, all of this comes to bear when someone's being seen by a primary care provider, including a pharmacist. So I'm very excited to think that there will be more caregivers available, more conveniently to patients, but for that care to be safe, it has to be integrated through an interoperability solution set, so that the pharmacists can get the data they need, and then they can share back with all of the other care team members the data that they produce.
Yes, can I put that on a bumper sticker? Shelly,
I-
over to you.
I got a better one for you.
Yeah.
This is going to sound slightly tongue in cheek, but I mean it. Thank God for pharmacists. I'm going to have a shirt created that says, pharmacist saving my bacon since 2002, because I used to practice in an academic medical center, and I was fortunate. I had clinical pharmacists more often than not rounding with me on a daily basis. And the things that they know and the insights that they bring to complex medications and the time they spend with the patient, give them more to do. I love pharmacists, and I'm so happy that in my company at DrFirst, we have a plethora of pharmacists that I get to work with to help address these challenges that we're talking about today. So yeah, make that bumper sticker, saving my bacon since 2002.
I love it.
Well, I thank you very much. This is music to my ears and to the CEOs of the professional organizations that I report to, because this is exactly what we're looking for as pharmacists. We have pharmacists that are embedded in physicians' offices. We have pharmacists that are embedded in clinics. We have pharmacists that are in hospitals. We have consultant pharmacists in long-term and post-acute care settings who are working in this environment. And this is the main issue that we deal with on the pharmacy side. We're not recognized in the Social Security Act as a provider, therefore we can't bill for clinical services like other providers can, and our services are bundled into the dispensing of the medications. But you can do a comprehensive medication review and not have a dispensed medication that has actually been done. So our reimbursement models are evolving and changing, such as what Stephen brought up. We have 50 plus state boards of pharmacies in the United States and territories that are out there that oversee our scope of practice. And we have to go through state legislators to change what we're recognized and how we can get paid for our particular types of services. And that's sort of what we have to deal with in order to make pharmacists more available in those locations, such as in rural areas and in other aspects. We also have collaborative practice agreements that allow pharmacists to actually evaluate and dispense and prescribe medications for certain situations. A good example of what we saw with COVID is the ability to dispense Paxlovid, to prescribe and dispense Paxlovid for patients with COVID that meet certain criteria. Again, we have the problem of not having the access to information, and we are kept out of having the access to the information to do our comprehensive medication review that is needed. And so having the technology, and why the CEOs of the professional organizations for pharmacy have really stepped up to the plate to work through the Pharmacy HIT Collaborative and the standards development efforts to increase our ability to what we call digital transformation, leveraging the technology to change the pharmacy business model to include clinical services that can leverage the technology so we can be more efficient in our care team participation. And this is one of the reasons why we developed the FHIR resource of the Pharmacist Electronic Care Plan, and are working on the SMP project for transitions of care to transmit information, medication-related information. And medication-related information is not just a reconciled med list or even an inactive med list, but to get other comprehensive information in relationship to the care of patients as it relates to medications, such as social determinants of health information. Can the patient afford their medication? Is there certain food insufficiencies that are out there for patients with diabetes or hypertension? Is a transportation an issue? Is housing an issue? Do they need a refrigerator? These are all the other areas. Cognitive and functional status. Can the patient understand the medications? Do they need a caregiver or a medical assistant to help with their medications? Compliance packaging. There's a whole range of other information that pharmacists can participate participate in the care team in improving the outcomes, reducing adverse drug events, and helping the patients with their quality of life.
You know what I love about this panel is you all keep leading me into my next question. And I love this. So that was such a good leading question. And this will be the last moderated question. Then we'll get to audience Q&A. And I know the panelists have been answering questions as we go, and we've worked a few in, but please, if you're in the audience and you have other questions, please put them in the Q&A box and we will get to those in a second. So my last question for you all is, when we look at the broader impact of this data in the broader look, how can organizations leverage multiple data types to enhance workflows and care for patients? And I was thinking particularly, you know, at Health Gorilla, we have both the pharmacy data, medication data, and we have SDOH data. Our SDOH risk scores can be a great way to provide some of that directionality that you're talking about, Shelly, with saying, you know, hey, it looks like somebody has a transportation issue. Can we go ahead and do a mail option for their medication? So how do we leverage multiple data types in order to provide the best care? Colin, I would love if you started with this one and then we can move to everyone else.
Do you think Stephen should take first crack at this one? I'm going to defer.
All right, Stephen.
No problem. Yeah, I mean, I think the challenge really is bringing the data into the clinical workflow. You know, when you have data from many sources, whether you're a pharmacist, a physician, a home care, you know, professional, you know, you're using whatever system you're using. And having all of this data available is terrific. You know, the fact that the Health Gorilla and others can bring data from multiple sources, can integrate it, but I think the challenge is getting it into workflow. And what we have as an opportunity there is to leverage APIs, application programming interfaces, such that that data can be inserted into the technology that the individual is using, be they a pharmacist, a physician, et cetera. So I think I'm very excited about that. Not only this multiple sources, the advancing technologies, the advancing standards for getting this information in a way that it can be consumed, but then this ability through the APIs to get it in front of the eyes, into the mind of the individual who has to make a decision, be they the patient, a caregiver, or a clinician.
I think, yeah, sorry, real quick, Jim. I think Stephen brought up a real good point in that there's also, you know, we're about to go, or we have gone from not having enough data to at times having too much data or duplicative data or conflicting data. And I think there's a tremendous opportunity for the idea of bringing that data together to give a more cohesive view in a very thoughtful and clinically relevant way, as well as making sure that we are deduplicating and hiding, you know, the redundant. And so that, I think, is a tremendous opportunity that we're starting to tackle as well. And then I'll give it back to Jim.
Oh, yeah. Hey, just to pile on to both of those excellent comments. I think one piece is about the data getting into the workflow. Absolutely. And unfortunately, workflows is plural right now. You know, you've seen one workflow, you've seen one. So hopefully this will lead to more standard workflows. And where I'm headed with that is, I think, Shelly, as you were mentioning, one thing we like to say is that maybe it's too big for a bumper sticker is medicine is a high risk endeavor and it's a team-based sport. And I hope that the national infrastructure also addresses standards around communication between these entities. For example, Colin, you know, also having worked for 20 years at an academic institution, we had the privilege of being insulated from some payment models and experimented with teams that had all these different pharmacists on it, care coordinators. And we realized that using technology could bring down the cost, right? But the problem we ran into was that, you know, the Blues have one way of doing it. This insurance has another, this has another, and Medicare does, right? And so for the clinician trying to take care of a panel of patients, they get their lunch eaten because every single patient, it's a completely different set of resources and workflows. And where I'm headed with this is I hope that all of us can land in a place where technology enables us to ignore some of that. And if I'm dealing with patient A and Shelly's the pharmacist remotely somewhere, that the system allows me to know that, allows me to know that she's the one or her team that's partnering with me. When I move to patient B, patient Stephen Lane, then it's another insurance company, but it's the same infrastructure so that it becomes easy every day. Because the old sitting on the dock of the bay, you know that song? One line in there says, I can't do what 10 people tell me to do. And so I remain the same, right? So if a clinician can have it be that whoever they see, the technology allows all these different energies to come up together with no special effort, then we have a chance at this.
You bring up a really good point, Jim, and I could tell you we've over the last 13 years of the Pharmacy HIT Collaborative, we worked on several projects to help our system vendors, the pharmacy system vendors, to work on workflow. And one of the areas of why we were so successful with the pharmacist electronic care plan in the independent community pharmacies started with a project out of Community Care in North Carolina that was paying pharmacists to for high-risk Medicaid patients across the entire state to manage their medications, and they had to input the information into a web-based portal. So instead, what we did was leverage the pharmacist electronic care plan, work with these 19 system vendors to work out a different workflow for their clinical documentation modules. In doing that, no matter which patient those pharmacists saw, they were able to document in a very consistent way to an export of a care plan that was highly codified, that allowed them to work their own workflow and their own capability. And we saw a 300% increase in productivity when we did that. And that's one of the reasons why the National Community Pharmacists Association formed the Community Pharmacy Enhanced Service Network that actually sent this model across the United States, and it's in 45 states, and why we have such a high use of the care plan. Now, we still have to use an intermediary to capture that information because the others of the care team are not capable of doing what we call the read-write capability. They could read a care plan, but they can't integrate it into their own workflow. And this is why any system vendor has a problem of integrating that information. And so what we're working on now is using clinical decision support tools like CDS hooks to actually bring information into the right point of the workflow of the clinicians who need to review this highly codified information into their workflow. And I think one of the reasons why the HL7 EHR work group is working on burden reduction to leverage those types of tools into the clinician's workflow to capture information. Because if you're just taking a PDF and throwing it into a file, how do you expect those physicians to review that information in a way, unless it's at the right place, whether it's a dashboard or whether it's at the right point of making a decision, whether that's electronic prior authorization or whether that's care planning or even medication reconciliation? How do you know when to do what? And so our EHR vendors have to begin to focus more on the workflow internally within the systems so that the exports can be more meaningful.
Yeah, I was going to give another, it reminds me of your comments here, is that as we're being successful with the information and its meaning following the patient wherever they go, you know, now already clinicians are like trying to find a needle in the haystack, right? They're trying to find the pieces of information that are relevant, right? And the haystacks are getting bigger, to your point, you know, and so, you know, the hope of getting to semantic interoperability, syntactic interoperability using augmented intelligence, thank you, Colin, not artificial, is to create metal detectors, right? Because the haystacks are getting bigger. We need sophisticated metal detectors is the analogy, so that for whatever task's at hand, we humans are aided in what are the salient information that we need to bring forward. Computers should help us with that. And that's why, you know, we're just in chapter 1, as Stephen said. You know, this is a exciting journey, but getting past the introduction and the forward has been the challenge. But now you can taste it. We're getting to where it's going to happen. And what's going to be fun is to see the symphony of different business services that actually help us with metal detectors to find these needles and haystacks on for the benefit of better decision making for patient outcomes, but also for more efficiency. So these clinicians that are in short supply can actually get far more done.
Yes.
Well, I sound like an itinerant Baptist preacher or
No,
something.
no, I
know
love
I'm
it.
preaching in the choir here. There's a choir, and I'm going to start singing.
This conversation has given me so many bumper stickers, so many t-shirts, so many metaphors that I can use moving forward, and just been fantastic so far. Thank you to everyone. We are going to spend the last 10 minutes on a few audience questions. So thanks to the panelists for some of your written answers. There are a few questions in the chat specifically about the Health Gorilla solution. So I'm going to address those quickly, and then we will move to some of the broader ones. So first question here is, how does DrFirst use medication data already stored in Health Gorilla? Is DrFirst simply pushing their medication data into Health Gorilla? Is there some sort of data reconciliation? So the answer is yes, there is deduplication inside the Health Gorilla system. So we are pulling in the feed from DrFirst, and then we also have medication data from EHRs, and we are indicating which data is coming from DrFirst versus which data is coming from the EHRs, and we do have some deduplication. On that note, the second question was, when will the APIs be available? So right now, we do have documentation available, and this after this webinar, you'll get the recording of the webinar tomorrow. You will also get more information about our particular solution with DrFirst. And so we'll have additional information in there. And of course, if you want to talk further to our sales team, they've got all the great details ready to go for you. And I do welcome any other questions about our particular solution. Please send them our way, and we'll make sure to address them in subsequent communications out to the group. So we have some, great questions in here. I want to ask this one. We addressed it a little bit, but there's a question for Shelly in here. Asking because there seems to be an incongruency between inpatient pharmacists doing med rec and outpatient retail pharmacies not having time or access to do so, yet they are the ones who will most likely be able to bill for this service. Do you foresee the possibility for hospital pharmacists to bill for inpatient med rec?
Well, that's an interesting question. Realizing that inpatient pharmacists are using the EHR of the hospital system, example, Epic, Cerner, some of those, and the documentation by pharmacists and the Med Rec solutions are pretty standard, whether it's a nurse doing it or a pharmacist doing it. A pharmacist has more knowledge in medication reconciliation because they have an understanding of what to look for in terms of Med Rec and to help the care team understand the problems. In terms of outpatient services, such as in community pharmacies, access is our biggest issue. It's very streamlined, and we do have some software tools that help with MedRec solutions. There's a few that are out there that can be added onto their clinical, that brings in the information that we might see with Health Gorilla coming in so that an appropriate med rec can occur. But in terms of time and reimbursement, I mean, these are businesses just like any other business. And if we aren't reimbursed for the services we're providing, it's more difficult to provide those services. We're under regulatory requirement through the state boards of pharmacy to do that evaluation. And so they are just like a physician has a certain scope of practice, so do pharmacists, and pharmacists have to provide that comprehensive review of medications upon a new medication, or when a patient is encountered, to make sure that there aren't any over-the-counter items or supplements that have been added to the patient's care. These are part of what we do, but again, as I said before, this is part of their reimbursement model for dispensing a medication. And if you're not dispensing a medication, but just providing clinical services, we don't have as much of a reimbursement model in the ambulatory setting like we do in the inpatient setting, where our FTEs are covered by the pharmacy departments or the hospital itself.
Absolutely. Stephen, did you want to add something?
Well, I just actually had a question myself, and we were talking before about pharmacists providing care, primary care, medication-related care, but of course, many pharmacies now also house primary care clinics, where they might have a nurse practitioner or a PA or even a physician, on site. And I'm just curious, what are the opportunities, Shelly, in that setting for collaboration between the clinic site and the pharmacy side to be able to provide even more care?
Well, it's very similar to what you see in the inpatient setting. These are interdepartmental exchanges of information depending on the time and the FTEs that are allotted for those pharmacists to provide that type of service within mini clinics and other types of clinics that are being set up by Walmart, Walgreens, CVS, and some of the larger chain pharmacies. And so there are several models that are out there. And can it be done? Absolutely. But do we see that, if you're hiring a clinical staff in your clinic, are you leveraging your pharmacists, and are they pulled to do dispensing functions, or are they pulled to do clinical functions, is an intercompany policy decision.
And the last, thank you, Shelly. The last question that I'm going to ask for Q&A, and then we'll have kind of final words from panelists. Jonathan asks, how do we improve the quality of data? In my experience with numerous EHRs, there was very little quality control, lots of old and bad data, no processes to keep clean. We have talked about this, Shelly, with all the standards that you're working on. Colin, DrFirst has been a leader in figuring out how to have quality control on medication data. I open it up to anyone who wants to talk about the improving the quality of medication data.
Well, can I start a little bit just at the bedside?
Yes.
Because I think part, and I typed in an answer in there too. Part of the problem is cultural, right? It's who actually owns the med list as patients move between theaters of care that might not even be the same business entity, right? So if you just talk about in the hospital for a particular episode of care, you have how well is medicine reconciliation done at the beginning of the visit? How well is it maintained throughout the encounter? And how well is it done on discharge? And on discharge is particularly interesting because you may have super specialists who maybe a hospitalist admits a patient, but there are super specialists, HIV docs, transplant docs, that really need to take ownership of those highly specialized medications, right? And so part of the, in some hospitals, medicine reconciliation is done by multiple clinicians. In some, it's all done by the discharging doc, right? And so the cleanup of that medicine, when a patient's then discharged, and then they go and have a bunch of things at other hospitals and other clinics and come back in, the medication is stale. And I would say that there's a cultural issue of ownership that, to me, it seems like technology and pharmacists, if we could only align the business model, Shelly, like you're saying, there could be an overarching cross-continuum maintenance of those lists to make it better. And the good news is technology should empower it. The bad news is we're going to have to change. We're going to have to figure out a business model that actually supports pharmacists doing those kinds of things.
I would add to that, Jim. One of the things that we find with medication reconciliation, or who owns the data is owned by the person who's doing the med rec. So when you're approached in an encounter with that patient, whether it's in the hospital setting and in a pharmacy, in a physician's office, you're responsible for doing the medication reconciliation. When you share that with somebody else and they're continuing on the med rec process, people get confused that an active med list is good for a year. It's not. It's every time a new medication or an over-the-counter or a supplement is being done, that's when medication reconciliation needs to take place. And really the patient engaging in that is the best one to work with a clinician to reconcile their own list.
Shelly, wouldn't you say it's not even when a medicine's changed by a clinician, but it's when a patient goes to the pharmacy to fill it and baby needs new shoes?
Exactly.
And I'm not taking that cholesterol medicine for the next 90 days because baby needs new shoes.
Correct.
Actually, it's every time the patient goes to their pill box and makes a decision whether or not they're going to take the medicine. I mean, medication reconciliation, what I try to help my staff do is just say, what's in their body right now? That's really what I want.
There you go. Biometric
medication
markers.
adherence, yes.
Well, thank you so much to our panelists today. This was a fantastic discussion. In the last minute, 30 seconds. I would love to hear if there's one word or one bumper sticker phrase you want us to take away from today.
Can I add one thing real quick? Because there was a question that said, someone was saying, hey, when can I get access to these APIs or whatever, so that we can be alerted when a medication's changed on a patient, right? And the reason I like that is because that is exactly what all of this is about, right? If we can get where everyone's participating, there's record locator services. So when some encounter happens, the system can just alert those who need to know. Like I'm thinking great example of this, transplant. One of the use cases at HCA people are all over is we want to know when a patient's been seen anywhere, because
Right.
people do not understand how medications interfere with transplant meds, and it can cause rejection. And so that's a beautiful use case. When this is all in place, you can imagine services that make it really easy for the clinician not only to be alerted, but did someone actually change a medicine? Or even better, did they, when they went to fill the prescription, did they fill it? Or even better, what Steven said, when they're going to their pills, are they taking it? The power of what's coming should allow for those things. Sorry, that's bigger than a bumper sticker, but thought it was important to call out.
That's a great ending, though. I can't improve on that.
You
Well,
did.
my one tagline is pharmacists are an integral part of the care team.
Yes.
And I'll throw in, let's automate Med Rec.
Woohoo! Good
Awesome.
starting point.
Yes.
For the next webinar.
For the next webinar. Well,
Mhm.
thank you so much. Thank you to all of the attendees. You will be getting a recording of today's session and more information on the APIs that we do have available for our solution. So thank you so much for attending, and we'll see you all later.
Thank you.
Thanks, everyone.